I will get us started. Welcome, everyone. Thank you for joining us. I see we have a great group joining us today. Just to introduce myself, I am Dr. Portia Cornell. I am a senior research fellow at the Validitron and the Center for Digital Transformation of Health. And welcome to this installment of our Making Digital Health Real series. If you would like to know a little bit more about the Validitron and what we're about, there's a QR code up there, or you can go to validitron.com. And I will just start by saying I'm very delighted to be able to host this discussion and introduce my friend and colleague, Julia Adler-Milstein. She and I overlapped very briefly during our PhD programs at Harvard for about a year, and she has gone on to do really exciting and fascinating work at UCSF. But before I turn it over to her, I will just start by acknowledging the traditional owners of the land of the University of Melbourne, the Wurundjeri people of the Kulin Nation. And I will also acknowledge the Ramaytush Ohlone people, who are the traditional custodians of the land of UCSF. So with that, Julia, we're so glad to have you here. I can't wait to hear more about what you have to say today about the future of AI and healthcare. But I will let you give a little bit about yourself and your biographical details. And then hopefully we'll have a good 10 or 15 minutes for discussion at the end of your talk. Thank you so much, Julia.
Yeah, wonderful. Well, I'm so thrilled to be invited to this group, and I always feel like we do our work in so many different silos, and this is to my mind just another example of them. As I was looking up what you're doing with Validitron, it's just so relevant and interesting to the work that we're doing here on the other side of the Pacific. So. Yeah, I'm a professor at UCSF. I lead our division of clinical informatics and digital transformation, a bit of a mouthful, but share, I think, this interest in digital transformation. My background, as you said, was trained in health policy and was trained sort of as the US was entering its era of federal health IT policy making, with large scale incentives for electronic health record adoption, I think somewhat similar to what you had in Australia. And then sort of my research has followed like the trajectory of policies and technologies as they have evolved. And being at an academic medical center, it always said like, well, yes, the research side should work with the health system side. And it's been quite hard, frankly, to really get that partnership. I found until we have hit this AI era. And all of a sudden, I think we're really seeing that partnership feel mutually beneficial, where the health system is asking a lot of questions about these technologies and are they ready for deployment, and how do we decide once we deploy them if I would say, are they doing the good things and not doing the bad things? And so it's been really gratifying, I think, as someone who has done research in this field for many, many years, to now feel like we're in an era where like the research is directly informing practice, and that the practitioners are coming to the researchers with questions about AI and how to study it and assess its effects and how it should be sort of modified to have optimal impact. So with that as sort of a bit of background and context for the talk, oops. Let's move forward. There we go. What I do really want to focus on today is a core set of issues that I think are critical to closing the gap between the incredibly mind-blowing AI capabilities that we have, and they really are amazing. And if I think about just the past 4 years, what we've seen in terms of new capabilities that didn't exist or we couldn't have even conceived of, and now all the possible use cases for those capabilities, it's truly amazing. But as we all know, sort of to get an actual product ready to be integrated into an environment as complex as a healthcare delivery system is actually a lot of work. And so what we need to do is to figure out how to close the gap between the capabilities and health system readiness. As I alluded to, I think of my work and really the eras of work evolving as the technology evolves. And so, for a long time, I suspect many of us on this call were thinking about electronic health records as sort of the core enterprise technology where we needed to assess its adoption and impact and usability, and then, sort of pretty quickly transitioned to thinking about like interoperability of electronic health records and how do we build those capabilities and get them to work, frankly, something we're still working on here. And so to say that it ended in 2020 is actually not quite accurate, because that's proven, I think, quite challenging. But with, then the start of the pandemic and sort of overnight, dramatic expansion of the use of telemedicine, and then like a whole bunch of questions again about whether we're using telemedicine efficiently and effectively. And then this sort of current era where we are now seeing AI tools, and just sort of in each of these eras, we ask a very similar set of questions. And I think use methodologies that, for people with backgrounds in sort of health services research and applied clinical informatics have been relevant across these different eras. But there are differences in terms of the technologies themselves and how we think about studying their impact, why even we have them adopted. And I think this AI era is the first one in which it's really been led by the technical capabilities themselves, right? There wasn't a large-scale federal policy push for adoption or a pandemic. This is the first time where we've really seen technology capabilities like leading the start of this new era. And so in that way alone, I think it's felt different because we're really thinking about, now that we have these capabilities, how do we as I said, turn them into products that are ready for real world use. There are a lot of different ways, to talk about AI. And generally in this talk, I'm not going to be specific about when I say AI. It could be, a machine learning algorithm. It could be a generative AI tool. I'd say in general, I will be thinking more about the tools that we have ready for deployed in clinical settings, which tend to be sort of, again, more geared around healthcare delivery. But just to say, any of these tools could also be as relevant to sort of patient-facing applications. And there are a couple points in my talk where I'll talk about some of those applications. But then there are also, applications to sort of like research and drug discovery. And so, my talk won't sort of go into some of those other areas as much. It'll be focused, more on the clinical setting and tools that are used there, as well as in sort of adjacent areas like patient-facing for the purposes of healthcare. So as I alluded to, I think, one of the early hallmarks of the AI era is that technology is moving much faster than people and processes. And I think we really won't see the impact of AI materialized until, the technical capabilities are really translated into applications that solve our current pain points. And right now there's, you can just see that there's sort of lots of ideas of like, well, maybe it could do this and maybe it could do that. And a lot of sort of leading with the technology rather than sort of making sure that we're leading with the problem space and like, what is the actual problem that we are trying to solve here? So I've seen that we really need sort of a lot of discipline in this era to say like, let's return to the problems, right? What are the major problems we're trying to solve? And then thinking about, does this capability enable us to develop a product that solves that problem? I like this particular graphic because, again, I think it shows this, what we're seeing where, we have a lot of invention, something like, LLMs that then can lead to innovations in terms of how we use those inventions, but you really don't get the diffusion until, it's turned into products that can be adopted. And I feel like, we're very much in this early adoption phase where we have individuals, a lot of companies, right, that they're creating very like special purpose applications using AI. And most organizations are on this sort of learning curve of like, how do we assess all of these, fairly narrow tools and decide which ones to adopt and then adopt them in a way that ensures, safety. And then if you look at the research that's out there, like we're still doing a lot of surveys to ask people, like, what have you adopted? What AI governance framework do you have in place? And so I think, one of the major questions is sort of when will we move from the early adoption phase to this adaptation phase where we're really sort of retooling the whole system around AI capabilities at a more general level. And I'll talk about that a bit more. And then we'll actually be able to see the impact of AI in broader economic indicators. I think we're just too early to really see that. And then obviously how sort of organizations adapt and all the laws and norms is like a whole big discussion, and that can be helpful or can be sort of slow down or distract this progress. So a lot of moving parts right now as we sort of evolve from this early adoption stage to the adaptation stage. This is another graphic that I think is helpful just as we're level setting here. And I actually don't know that I agree with like where they put everything on this 2x2. But I think we all understand like the concept of technical readiness, like how technically sound is a tool. What I find interesting is this dimension of market readiness. Like how do you determine like how ready our healthcare system is to take up and use these different types of tools? And that I think is a squishier concept, and something that, if we can mature our understanding of market readiness, it will really help us design tools that can be quickly adopted. But to do that, I think we really need to dig into like, what do we mean when we say market readiness? Is that about like the problem space, or is that about something around incentives, and our incentives aligned for, for that tool to be well adopted? So when I see graphics like this, I always like them, but then I'm like, well, but what does market readiness really mean? And how do we dig into that? So as I dig into this concept of market readiness, I think I quickly encounter this small, but I hope growing field that talks about delivery science as a concept, and specifically, how do we develop delivery science for AI in healthcare? And I like delivery science because I think it is juxtaposed to the idea of data science, right? And we've seen an explosion of data science that has really led to the tools that we see out there today, right? So taking large sets of clinical data and developing a tool that can predict, X, Y, or Z, which is great. But if we don't have the complementary delivery science, we're never going to be able to figure out, again, that market readiness piece, like how do we actually get this into practice? And again, I saw the first slide that the Validitron put in, right? Some of the statistics that I think are also pointing, right, to this like lack of market readiness tools that exist and that we think are technically sound, but are not widely adopted. So this delivery science, I think, is starting to come into focus. And so I'll just sort of show you a few pieces of what I think of when I think of what is health AI delivery science. It does come back to, I think, starting with the problem. What is the problem we're trying to solve? And then moving into, designing an intervention. And this is where the AI comes in, right? It's the AI that powers the intervention, and usually is around bringing new information or a new function that will help solve that problem. And then you move into, again, things that we're all familiar with from just digital health work in general, right? The implementation, evaluation. Again, there are a few pieces of this that are unique to AI. So in our evaluation toolkit, we've had to think about new things like, modeling, understanding, how models may drift in their performance, right? Like we didn't have those issues back in the old world of more rigid clinical decision support where there was no such thing as drift. So, there are pieces of this that are new, but in general, this is like a framework that I think is very familiar, but we just need to be disciplined in applying it to AI tools, and remember that it's like not about the tool, but it's about the entire AI enabled system that you're going to build around that tool. So it's I just think, sort of repurposing capabilities that we're familiar with, like process improvement, design thinking, implementation science, to take an AI tool and think of it in this way. So that's just sort of like the concept of health AI delivery science, which I said is, I think, a familiar one. But where I then go next is like, how do we actually define the priorities for this science? What are the key scientific questions that we need to be thinking about that underlie a health AI delivery science framework? And I think some of them are sort of well understood. And if you go to a lot of these AI meetings, you will hear about them at every single one. And so I put in sort of the top right quadrant topics that I think there's a lot of attention or awareness of the issue and that are super important if we're going to close this innovation and diffusion gap. So some examples of these are the need for AI governance and new types of leadership roles. They tend to be the ones that sort of drive the framework for AI delivery science. How do we define the problems? How do we match AI solutions to those problems? And so our health system, for example, about a year and a half ago, named a new chief health AI officer, who is the person that's in charge of understanding our health system's needs and then looking at the tools that are available and deciding, do we buy these? Do we build our own if we don't think that the market's providing quite the right solution, all the way through to thinking about our AI governance and monitoring. So again, I think the need for these new leadership roles is well recognized and very important because we do need people who can really specialize in this area. As I said, I think talking about issues like AI bias and drift and developing the methods to detect those, also very well understood and very important. I think there is more work to be done within some of the nuance of that. So like when a model is biased, like what does that actually mean? What is the degree of bias at which we should be concerned and intervene? So we talk about these in general terms, but I actually find that when you do this work within the context of an organization, we'll look at a tool and we'll see differences in performance for different racial groups, for example. But then it's like we still have to make a decision. Well, should we move forward with this? Like if it's better for both groups than current state, will we accept differential performance for one group over another? So then you quickly get into, I think, ethical questions around this. And again, that's, I think, another area that's being developed is sort of the whole ethical framework around assessing AI tools. And then last but not least, at least here, and I suspect there too, thinking a lot about like, are we going to create a new digital divide with AI tools? And will there be some health systems that can afford them and understand how to sort of adopt them and implement them well, and others that don't? Again, we have talked about the digital divide in like every era of health IT adoption. We were worried about it with electronic health records and continue to think about that. But again, because of this need for sort of new governance and new leadership roles, as well as the cost of adopting the tools themselves, there I think is a real potential for a digital divide, and some creative solutions that we're seeing emerge for how to ensure that that doesn't happen, or at least to minimize the divide. So again, I put those in the category of like things that are talked about a lot and that I'm sort of not worried about, not because they're not hard problems, but because like they're on the radar and people are thinking about them, talking about them, and experimenting with how to solve them. So what I want to spend the rest of my talk focused on is issues for which I think they are as important as those, but for which there's just been less attention to or awareness of the issue. And I won't claim to have the solutions here, but I think that at least by talking about these issues, hopefully we'll raise awareness and result in groups like this one thinking about how to incorporate it into their own research. So I'm just going to go through what I think are the 5 key questions for health AI delivery science that need more attention. So the first question is, and I apologize for the shorthand here, I will translate it in case these are not widely familiar, but here in the US, we talk about EHI, electronic health information, which is basically shorthand for saying patients that have access to most, if not all, of their full medical record. This has been like a huge priority in the US because we've always said that patients have a right to their health information, but now we actually have a whole policy framework around ensuring that they have relatively seamless electronic access to their whole health record, which means in theory, if I went and got healthcare anywhere, I should be able to download electronically an entire copy of every piece of information that healthcare institution created about me and my healthcare that I received. So with individuals having access to that is one piece of it, but really how do you make sense of it is the opportunity for large language models to sort of take what a patient may have access to and help interpret it and make it actionable. And so the question is sort of, are these two going to finally usher in this long-awaited patient engagement era? And if it does usher that in, are we ready? And we, I mean, sort of the healthcare delivery system. Like, are we ready for patients who can work with their health information in a fundamentally more sort of sophisticated and nuanced way? And what that then may lead to in terms of their understanding of their health and what they might do next. And so again, just to dig into this in a bit more detail, there's been, I think it's now probably been over 10 years that like you could download your medical record to a smartphone, and there were, Apple had their health kit, Google had, their equivalent, and you could do some sort of very basic, accessing your information. And we did a study that ask like, well, how often are patients actually doing this? And you could see we got data from, I think, 12 or 13 health systems, and found that like less than 2% of their patients like took advantage of this opportunity to download their data and work with it. And largely because it like wasn't that helpful, right? Like you could see your test results on your phone, but like you could also go and see your test results on a patient portal. And we didn't really empower patients in a fundamentally new way. We just gave them access to information, but not any ways of sort of interacting with it or querying it or, trying to better understand what they were seeing. And so, again, that's why I said this long-awaited era, because I think we've been trying to get patient engagement with their information for a long time, but we've never really given them the tools to make that a reality. But that is changing. And one of the seminar series that we put on in my division is called Innovations at the Intersection of AI and Diagnosis. And earlier this year, we had a panel with several different patients that basically showed that by giving them access to their electronic health information with large language models, they were basically able to self-diagnose. In one case, a mom was able to diagnose her son after, I think, 5 years of her son being misdiagnosed and getting basically ineffective treatments. And she basically fed his some of his images into ChatGPT and asked some like fairly basic questions. Like she didn't even have super sophisticated knowledge, and was able to come up with a diagnosis that had not come up before, and then go back and that was actually the accurate diagnosis for her son. So I think, this is like, again, has the potential to be transformative. I think we need to think about, again, how to help patients know how to do this and what some of the questions are to ask. But most importantly is like when they get information, that's going to then come back to the health system, and we're going to have to be ready to take their insights seriously and figure out when it is good information and we should actually act on it in the case of this diagnosis that had been missed. But many other cases, it might not actually be better information resulting in a better course of treatment. And so I think we need to both empower patients to use this capability well, but also be prepared for having the conversations and really determining whether the information is accurate and useful. And how we do that, I think, is the hard part. But we're starting to see this real sea change, I think, in terms of what patients will be able to do. Okay, so let me move on to my second key question related to health AI delivery science. And as we have, again, more and more tools that can predict many, many different things, right? They can predict risk, they can predict, what the best next clinical step might be for a patient. We have to start asking ourselves, how do we know if the health system has the capacity to act on that? Because to basically be able to predict someone at high risk, but then not intervene, I think is, again, ethically problematic and may even, increase risk of malpractice and, other concerns. So as part of evaluating an AI tool, we need not just to say, like, does this tool do a good job of predicting whatever it is, but how do we also assess the capacity to act? And again, I don't think we've really developed the tools to do that capacity to act assessment systematically. And then I think the other really key piece of this is, like, do those leading AI implementation have the authority to sort of modify workflows or scope of responsibility to optimize AI impact? So it may be that you actually do have the capacity to act, but that the person who's sort of leading the implementation of the tool doesn't really have the authority to say, okay, well, we're now going to have our radiology MAs follow up with everyone on whom they've detected, something abnormal on a chest CT to get them, to come in for a visit. And so I think it's these two that go hand in hand, is both you need to have the capacity to act and the authority to modify the system to basically ensure that that capacity is implemented in an effective way. So we've seen, I think, many, again, examples of this, like not quite done well. One comes from our institution where we got quite close to implementing an AI tool for lung nodule detection, but then realized that our like radiology team didn't have the capacity to like follow up once a nodule was detected. And so we felt like we couldn't turn on that tool until we actually had the people clearly designated to do that follow-up, and we would have capacity to bring those patients back in for the follow-up care. So that tool actually is currently on hold right now, as we're understanding if we can build the capacity and have the authority to modify the system to be able to take advantage of that tool. Another example that my colleague Vinny Liu from Kaiser talks about is, again, the same thing. They had a suicide risk prediction tool. Again, even a more obvious case of why it would be so problematic to not have the capacity to act. And they actually went through, I think, a pretty thoughtful process of thinking about like, well, how many people do we think we will catch with this tool? And then can we intervene almost immediately? Because you could imagine that, like, if someone comes back as high risk, like you can't wait 2 weeks to follow up with them, which might be fine for lung nodule detection, but it's certainly not going to be okay for suicide risk. So again, how could they identify, once this tool existed, like what capacity they needed in order to make this tool, sort of work in the real world and again, in a safe and effective way. Another example of this is same-day mammogram follow-up. And at our safety net institution here in San Francisco, there's actually an AI tool that can read a mammogram and basically determine whether there's an abnormality right in the moment that the patient is still there, and then ideally do the follow-up like while they are still there so they don't have to come back for a follow-up. But again, that requires the capacity, right? That if you need to be able to figure out how many people do we think will have an abnormal mammogram reading, and do we have the flexibility to that day do the follow-up? Because if not, again, you're predicting something with no ability to act on it. So I think we're just going to see more and more examples of this where we need the ability to understand what is the capacity that's required. And then if you don't have that built in, can you, do the people leading the implementation of the AI tool have the authority to change things to create that capacity? And if not, again, I think we'll just see more and more tools that like really shouldn't be implemented until we have an understanding of whether these two pieces are in place. Again, I once you start looking for things, you see this pop up, and I do think that there is, again, some growing recognition of the importance of these dimensions of assessment of AI tool readiness. This is an example of a paper that came out in 2019 from a group that said, basically that end users, including clinicians, health system leaders, may be particularly sensitive to the limited capacity of existing teams and providers to respond to a new alerting system. So again, I think it's pointing to the same issue of capacity. Here's another place, again, where I found some signal of awareness of this issue. This is another version of sort of the health AI delivery science framework that I showed you. This is, you may have heard of this, came out of a group at Stanford, the FIRM, Fair, Useful, and Reliable AI Model Assessment Framework. And as you can see in the intake interview piece of it, there are some of the questions that that point to this capacity. So in the second one, usefulness estimates determined by workflow simulation, given the cost of the action, its benefit, and work capacity. So there's the capacity piece. What is the theoretical utility? So to answer that question, you need to have an actual way to measure work capacity and determine, whether there's utility. So in general, this is, I think, a great framework for doing some of the work to do the assessment of a tool in order to determine whether, again, it's ready for deployment. And then what I love about this is like sort of all the technical things come in stage 2, and you really focus on the what and why in stage 1. Again, with this capacity thing, I think being the key piece we need to spend more time thinking about how to develop. Okay, so that was question 2, the capacity and authority. Question 3 is really about the optimal unit to which to apply AI, and then starting to think ahead to how the units will interact. And at the end of this, like, what do we have? So let me just piece that apart a little bit. So right now, I think what we're seeing is a lot of tools that do like isolated clinical predictions. Again, they predict an abnormal, whether there's an abnormal mammogram, or they predict, suicide risk or lung nodule detection, right? We could probably come up with a list of 100 AI tools that are out there that make some kind of an isolated clinical prediction. And if the rest of the workflow that sits around that clinical prediction is not AI enabled, then the AI is fairly isolated, right? You're just introducing sort of one new thing into a workflow that's otherwise not AI enabled. And so the question here is like, is this going to be our approach? We just implement, hundreds of tools that each predict sort of one thing as part of a standalone workflow. As you can suggest, right? Like, I think it's unlikely that approach really scales. And so then what we're seeing is that there's also AI at sort of a higher level unit, where it's an AI tool is really intended to support not an isolated prediction, but an entire task or process. And so, right, you could think of like an AI scribe as an example of this, where they're really trying to support a set of documentation related tasks, or AI that's intended to help you summarize a chart, for example. And so we're seeing, I think, these isolated clinical prediction tools, and then we're seeing tools that are trying to chunk off like a bigger task or process. And then we're seeing tools even at a higher level of scale, especially as agentic AI comes into sort of a more mature product stage, that are really thinking much more about clinical and system operations at like an entire sort of unit or like we have some of these tools that we're starting to deploy for the ED, right, where it's helping us monitor throughput and make predictions about, bed availability, for example, as part of a broader view of system operations. And so what I'm trying to build towards, right, is that we have to think about not just each tool and what it does, but like, how are all of these tools going to start to interact with each other? Because you could imagine, right, that you have, a tool that's thinking about chart summarization, and part of what it's summarizing is the output of an AI clinical prediction tool, right? So these tools are going to pretty quickly start to bump into each other, and it's going to be a question of like, do we understand how those interactions will work? Like, how will an AI scribe understand how to make sense of something that's coming out of another AI tool? Even just how AI tools will summarize content generated by other types of AI. And I think there's been some really interesting work that's basically shown that there's like very strong preference that really manifests in the form of clarity when like an AI tool is summarizing something that was written by the same tool. So basically, if you're like ChatGPT does a better job of summarizing and understanding its own content than if you try to feed it output that's come from Gemini, for example. So like, there's all of these going to be, I think, all of these different types of interactions that we're going to need to be able to understand and know to look out for these like potential interactions that could sort of degrade performance. And that's tricky because like, even just understanding, absent AI, like all the sort of interdependencies of how information is generated and used to like make decisions and workflow, it is complicated enough. And then you layer all these different types of AI tools that exist at different units. I think it becomes even harder to really be able to picture at a system level, like how these are all working and interacting with each other. And so I do think that maybe, where we may be headed towards is a model where, where it's really a closed loop autonomous AI system that's doing a lot more directing of clinical actions and tasks that should occur. Because I think it's going to be very hard for humans to understand this, how the system is operating at a whole, and whether there's a need to sort of optimize in one area. So we might actually say, like, we want to predict less of XYZ because we don't actually have the capacity to act there, but we should increase our focus on predicting something over here where we do have the capacity to act, potentially because that actually improves outcomes. So can we really think about AI as the brain that understands the entire system and can actually think about these interactions and how to manage them in a way that optimizes outcomes? This is, again, I think, quite future state, but I don't think too far off. And the question will be sort of at what unit there is, or sort of at what level there can be human direction and oversight of this. And you could imagine that it could be something as coarse as a health system that says, we would like to maintain our current levels of quality while increasing revenue by 10%. And like, that's the input to the AI system that then figures out like how to reshuffle prediction and capacity and actions and who is scheduled for what type of appointment to achieve that outcome. And so, again, I don't have a crystal ball to know, but I think that this is going to quickly get so complicated that we are going to need like a layer of intelligence that can sit over sort of all of the pieces to really understand how they interact with each other and how to make trade-offs to optimize different kinds of outcomes. Again, lots of ethical questions and other pieces that may come up with that. But I think that is sort of where this whole question of like unit of AI is going. I think we're going to move from isolated clinical predictions, which are the most common type of AI tool you see today, to potentially the full other end of the spectrum, where it's really sort of closed loop autonomous AI that's telling human actors sort of how to allocate time and resources within different parts of the system. Okay, so there's sort of an addendum that sometimes comes up in this discussion, which is like this whole question of like EHR developer market power and AI pricing models. I think part of the reason that the isolated clinical prediction tools aren't going to be our future is because right now you have like a company that's making one tool and wants us to buy that one tool, and like it just doesn't scale from a cost perspective, right? We can maybe buy a few of those tools at the start, but we're not going to be able to buy individual tools from thousands of companies that make, all different pieces of the puzzle. We're going to need to like buy an enterprise solution at some point. And already we're seeing the impact of that because as our EHR vendor, who is Epic, makes more and more EHR tools available and offers them to us at a bundled price, it's much more appealing to just say, well, yeah, we'll just use the Epic tool. It comes with the bundled price and it's already integrated in, and sort of we know will work well within our broader system. So you can see, I think, that some of the pressures of the market, coupled with the fact that we have entrenched EHR developers, means that like EHR developers could play a really central role in how this all plays out. And that could, again, be a whole other set of discussions around whether that's good or bad, and do we need policy interventions to create a more level playing field so that it's not the EHR developers that have so much control about how AI evolves. And happy to talk about that in the Q&A. Okay, we're going to move through to the end here so we have time for Q&A. Question 4 is really around how to establish and sustain robust ongoing AI monitoring. This is an example of how we structure our AI oversight process across the life cycle. So we bring in tools at a discovery phase, we do development and evaluation, we then integrate it and do an initial pilot, and sort of if everything looks good, then it finally moves into enterprise deployment. And so many of the tools are at the start of this process because, again, we're sort of at this early stage of AI market readiness. But what we're starting to see is more and more tools that we have deployed that now need the monitoring phase, where on an ongoing basis, we are assessing whether the tool is performing well, if anything has gone awry, and then knowing how to intervene. So we've spent a lot of time at UCSF and actually got a philanthropic gift to really go deep on AI monitoring. And it's allowed us to stand up what we call the impact monitoring platform for AI in clinical care that has these different components. There's sort of a real-time monitoring dashboard where we track metrics for each tool, and you can sort of visualize how they're changing over time. And then this is the part we're working on now, is sort of figuring out the real-time alerting part of it. So if we see performance of a measure change, like who do we tell and what would they do about it? And so we're starting to connect back our own technical capabilities to some of that question around capacity to act. There's a data integration layer. We have an AI model repository that sort of supports some of the governance and compliance, so we can know like if an AI model version history changed, for example, because that could explain changes in some of the metrics that we monitor for, and then reporting and analytics coordination. Happy to talk more about this again today or offline, but part of what has taken the most time, I think, is just figuring out what measures and methodologies we should employ for ongoing monitoring. And so right now we're doing this by consensus process that starts with a literature review. And I think we've gone very researchy, so to speak, in terms of trying to do this very systematically. But pretty quickly, we're going to need to figure out how to scale this, because we can't do this, as I said, for every AI tool that we'll be looking at. But this is just an example of our first dashboard for AI scribe monitoring. Again, spent a huge amount of time on each of the measures that are on here. This is just a subset of the measures too. These are more the utilization measures. Then we have a whole set of impact measures that we monitor for as well. And now are really thinking about this last piece of real-time monitoring, which is like the thresholds for alerting and like who would be alerted based on a substantive change in a given measure. So again, this has been a lot of work. My hope is that this will scale, and scale not just within our institution, but like scale across institutions, so that each institution doesn't need to develop as much sort of infrastructure and sort of human capital time to be able to develop a robust approach for AI monitoring. And there are also, I think, some interesting commercial tools that we're seeing come out to address this space. Okay, last but not least, optimal investments to create an AI-ready workforce. We have had a lot of conversations at UCSF, and I suspect elsewhere, about like what types of training should we give our staff on both the health system side and on the campus side to be ready to take advantage of AI tools. And what you see if you look out there is like there are a lot of groups that have developed curriculum around this. So the American Board of Family Medicine has developed some sort of geared towards family medicine specialty. The one on the right is really about sort of focus on like AI for diagnosis. So there's a lot of these like curriculum that are out there that you can, pull in and take advantage of. I think some of the harder questions are when we have, for example, a tool like AI Scribe that we think actually changes the nature of the learning process and what it means to be a professional in a clinical setting. How do we think about like tool deployment and whether, for example, like, can we give our residents an AI scribe, or do they need to demonstrate a certain amount of proficiency before we would give them a tool that could help them write their notes better? So I think a lot of these issues are really coming to a head around an AI tool that's taking a piece of clinical work away and trying to figure out what levels of skills or competencies does a clinical professional need before we think it's frankly ethical to give them a tool that might sort of prevent them from developing that skill fully. So anyway, there's been some really interesting conversations we've been having around that, and we're trying to look to others in terms of what decisions they're making. And so the central tension here, I think, is like AI has the potential to upskill, and that's why we're talking about AI curriculum and training people, but AI also has the ability to de-skill. And so how are we thoughtful about doing sort of as much upskilling as we can while avoiding de-skilling? And again, I think this is just like a key question that many institutions are wrestling with, because the upskilling requires investment and the de-skilling requires determining how to assess a level of skill in order to determine if someone is being de-skilled by AI. And that's actually not as easy to do as perhaps it sounds. So a lot of interesting questions again around optimal investments to sort of manage this tension. Okay, so those are the ends of my 5 questions. I hope that they resonated in your context.